Adjuvant neoadjuvant chemotherapy is usually meant as a treatment to increase the chance of a cure of a patient. In patients affected by adult soft tissue sarcoma, adjuvant and neoadjuvant chemotherapy cannot yet be considered a standard treatment, as it is very well pointed out by the last version of the ESMO guidelines. However, there are specific conditions and subgroup of patients in which neoadjuvant and chemotherapy, and more than that, also adjuvant chemotherapy can be proposed. Over the last few years, we had access to more and more data supporting the benefit of adjuvant and especially neoadjuvant chemotherapy in selected histologic types, and in particular leiomyosarcoma, undifferentiated pleomorphic sarcoma, synovial sarcoma, myxoid liposarcoma, and malignant peripheral nerve sheath tumor. Patients affected by these histologies, of course, primary, localized, and completely resectable tumor, in which the risk of death is more than 60% at 10 years, as established by using the nomogram called circulator, look to have a higher chance of being cured when a neoadjuvant chemotherapy regimen is added to surgery and, of course, when needed, radiation therapy. The clinical criteria are, of course, the histologic type, those histologies that I mentioned before, because these were the histology that were investigated within a prospective, more than one prospective study. On the other side, circulator takes into consideration patient age, histologic type, anatomic location, tumor size as a continuous variable, and the histologic grade. It is important to notice that this applies to patients affected by this histology when the tumor arises from the extremities and superficial trunk. The same data cannot be translated into the same histologies arising in different anatomic locations. Outside clinical studies, the most supported regimen so far consists in 3 cycles of neoadjuvant chemotherapy containing a full dose of anthracycline, meaning doxorubicin or epirubicin, combined with ifosfamide. This can be combined also with radiation therapy in a preoperative setting. It's interesting to notice that data from a randomized study shows that trabectedin could also be an option in myxoid liposarcoma patient at high risk of death at 10 years. So in that histologic type, trabectedin, even though not formally approved in this indication, could be an interesting option. We spoke about the most common sarcoma types and the most common location, but we know that soft tissue sarcoma comprises more than 80 different tumor types, and unfortunately we do not have data good enough to support the use or to suggest us when to use chemotherapy, adjuvant, neoadjuvant chemotherapy in all these histologic types. So there are histologies that are very aggressive and known to be very sensitive to chemotherapy, like angiosarcoma, in which even in the lack of prospective data, neoadjuvant chemotherapy is often offered. But as a whole, I have to say that each single patient need to be discussed in a center of expertise within a multidisciplinary tumor board, taking into consideration the histology, the tumor size, and the histologic grade to be able to take an individualized decision that can be shared with the patient. I also want to say that there are studies ongoing, so there are other conditions like, for example, retroperitoneal sarcoma, leiomyosarcoma, and well-differentiated, dedifferentiated liposarcoma, in which international studies are ongoing, trying to understand if also in that setting the adjuvant, neoadjuvant chemotherapy can add to the chance of curing a patient. In conclusion, there are some cases in which adjuvant and especially neoadjuvant chemotherapy can be considered a good option. Then many other sarcoma types in which instead it is important to see if there are clinical study opens available for patients in that condition, or otherwise specific indication to be defined within center of expertise.